All right, welcome back, everybody, from the break. I think for the rest of the program, we have two great talks on antiretroviral interventions, both for prevention and therapy. The first talk is going to be given by Raj Gandhi, who seems to be one of these people who's everywhere in infectious disease. In addition to being in charge of the HIV clinical services at Mass General, he's the chair of the IAS-USA guidelines on antiretroviral therapy. He is the vice chair of the IDSA COVID guideline. He's the infectious disease editor of the Journal Watch. I could go on, but again, he's everywhere. But today we're glad that he's here telling us about what's new, especially from the guidelines. Raj, welcome.
Thank you. It's great to be here, and looking forward to the discussion and your questions and comments. So, as Henry said, I'm going to be talking about treating and preventing HIV, and I will be giving you some hot off the press, literally, updates from the IAS-USA guidelines. Here are my disclosures. And then the next 30 minutes or so, we're going to summarize some treatment options for people with HIV. We'll describe some interventions to reduce cardiovascular disease in people with HIV. And the guidelines will also cover new approaches to prevention of HIV, as well as sexually transmitted infections. So just to acknowledge the incredible expertise of the panel, they're listed here, as well as the IAS-USA staff who really made this possible. But the presentation you're going to see reflects the work of the panel shown here. This particular guidelines was published on World AIDS Day on Sunday, so they're really very, very new. They're freely accessible, and the link is shown here. These slides will be shared. They're also available through the IAS-USA website. So please do take time to review in detail. I'm going to be going through some of the highlights, but there's a lot of content in these guidelines, and I think you'll find much of it to be relevant to your clinical practice. So as I mentioned, I'm going to go through not the entire guidelines because of time constraints, but really the following areas. I'm going to talk about when to start antiretroviral therapy, because there are some nuances here that are new, particularly around opportunistic conditions. I'll talk about initial antiretroviral therapy regimens, when and how to switch ART. As we know, this is becoming a more and more common clinical dilemma, is when and how to switch. We'll talk about weight gain, and we'll also talk about cardiometabolic complications, some very important new information here, biomedical prevention of HIV and sexually transmitted infections. And I'm going to conclude really on a very important topic on equity and HIV treatment and prevention. Near the end, I'll highlight some of the areas that we didn't cover in the talk, really for your further reading. And I'm going to present these guidelines in the context of a patient. This is a person I saw, a 50-year-old woman with hypertension who's tested for HIV. The antigen antibody test and confirmatory tests are positive. The CD4 cell count is 500, and the HIV RNA is 500,000. And when I met this individual, she asked me the following question. She asked me, when should I start treatment? What should I be treated with? And what should I do to remain healthy? And so we're going to touch on each of her three questions, as well as a few other cases as we go along. So just as context, there's been a dramatic decline in mortality among people entering HIV care. This is a study that was published a few years ago that looked at the span of 1999 to 2017. In the United States, adults entering care, and there was about 83,000 such individuals. What you're seeing in the graphic on your right is a narrowing of the 5-year mortality between people with HIV in the black dots and the general population in the open diamonds. And you can see that that gap in mortality has really been shrinking over those years. And this is almost certainly because of earlier initiation of therapy, as well as improved treatments. So let's go to the first section, which is initial antiretroviral therapy, when and what to start. And this, of course, is the patient's first question, is when should she start? And these guidelines have not changed. We recommend starting HIV therapy regardless of CD4 cell count based on the results of the START study. But what is new here is that there's even greater data, a new publication from a few years ago, just last year, supporting this recommendation. So adults with HIV and CD4 counts of greater than 500 were randomized to immediate versus deferred ART, deferred being less than 350. And the primary results shown here is that both AIDS and non-AIDS related events were less frequent in the immediate ART group, a reduction in the composite endpoint, but also in AIDS and non-AIDS related endpoints. The 9-year follow-up were published last year, and the excess risk of delaying therapy really diminished after ART was initiated, but some excess risk persisted. What that means is that you can show a long-term benefit to early ART initiation. And so that's why we continue to endorse initiation regardless of CD4 cell count. But what's new in the guidelines this year is a more detailed discussion, as well as some new advances in when to start ART in the setting of opportunistic infections and cancers. So ART is recommended within 2 weeks of initiation for treatment of most opportunistic infections. And in a few instances, ART is actually the treatment itself for the opportunistic infection. So for example, for progressive multifocal leukoencephalopathy, for microspordiosis, there is no antimicrobial therapy for those. And so ART is your therapy for those opportunistic infections. For other opportunistic infections like pneumocystis, like other common infections, toxoplasmosis, generally, as soon as the patient is tolerating their OI treatment, that's when you should be starting ART, and that's usually within 2 weeks of initiation of the treatment for the OI. We have a more detailed discussion of active tuberculosis without meningitis. In that setting, we recommend that ART should be initiated within 2 weeks after starting TB therapy, especially for those who have a CD4 count less than 50. There's been a lot of discussion over the years on TB meningitis, and this is because some of the trials that have looked at this issue have shown high rates of mortality with both early initiation as well as late initiation. So our recommendation is that people with TB meningitis be treated with steroids and TB therapy immediately, and that we recommend starting ART as soon as the meningitis is under control, and that's based on clinical and CSF improvement, and that's generally within 2 to 4 weeks of starting TB therapy. For cryptococcal meningitis, in our last iteration in 2022, we recommended that ART be started when the meningitis is under control, and that's usually 2 to 4 weeks after starting antifungal therapy. I'm happy to go into more details around the rationale, but it's really based on a number of studies, including here in the United States, where we have careful and monitoring of intracranial pressure where we can intervene, and we think that in that instance, the best time to start ART is within 2 to 4 weeks after starting antifungal therapy. On the earlier side, if the cryptococcal meningitis is under control, closer to 4 weeks if there's a delay in controlling the cryptomeningitis, and a topic we can come back to if there's interest. And finally, cancer is a growing problem in our patients with HIV, and we recommend initiating ART really immediately in the setting of a new diagnosis of cancer. With attention to drug-drug interactions, we provide 2 really useful resources. One is the University of Toronto has an outstanding discussion of ART chemotherapy drug interactions. And then, of course, the Liverpool site that many of us use for looking at drug interactions has good information on this topic as well. But one we call out are the Toronto and Liverpool sites. So the person's second question is, what should they be treated with? And here we continue to recommend bictegravir, TAF, FTC, dolutegravir plus either TAF or TDF with either FTC or 3TC. And we provide the recommendation for dolutegravir 3TC, a 2-drug regimen, but we do put a couple of caveats on here. We recommend it only if this viral load is less than 500,000. And that's because the data largely has been in that group, although there are some new data coming that were presented recently but haven't yet been published. We also recommend that that we don't give dolutegravir 3TC if 3TC resistance is present. So don't give this if you know that the patient has 3TC resistance, or if they have hepatitis B co-infection. And the reason for that stipulation is that you want tenofovir on board if you've got a person with hepatitis B co-infection. And for those 2 reasons, really, we don't think that this is a good regimen for rapid start where you may not have the hepatitis B status and the genotype back yet. But these are the 3 recommended regimens, with a couple of caveats for the 3rd recommended regimen. I want to highlight some of the new data around pregnancy. And so here are recommendations, and these are largely in accordance with other guidelines. So in a person with HIV who's trying to conceive or is pregnant and has not previously been on ART, Our preferred regimen is dolutegravir plus TAF FTC, and the TDF is a good option if TAF is not available. The reason why we put that at the top of the hierarchy is because there are good clinical trials data supporting the idea that there's good pregnancy outcomes and infant outcomes in people who get dolutegravir plus TAF FTC, even better than some of the other regimens. As an alternative, we, for the first time, and other guidelines have done so also, we've promoted bictegravir FTC TAF to an alternative regimen here because the data has been growing for bictegravir FTC TAF. And then ritonavir boosted darunavir, importantly, the protease inhibitor has to be given twice daily, plus tenofovir and FTC is our other alternative. The person who becomes pregnant while they're taking suppressive, well-tolerated ART, if they're on bictegravir FTC TAF, we endorse the continued use of bictegravir FTC TAF. We don't think that people should be shifted off of that because there's always a small chance that people won't tolerate a new regimen or have viral breakthrough. And so the data has been strengthening for bictegravir FTC TAF, and we recommend continuing it if someone is found to be pregnant while on it. And then last, and this is important, if you have a patient who had prior injectable cabotegravir for PrEP, for pre-exposure prophylaxis, then we, in that instance, suggest that you use ritonavir boosted darunavir, again, the protease inhibitors twice a day with tenofovir FTC, because of the concerns around integrase resistance, and you don't want to start an integrase regimen until you're quite confident that they don't have integrase resistance. And then finally, if someone is on cabotegravir rilpivirine long-acting, every 2 month or every 1 month injection, because of the lack of data, as well as at least one study suggesting low levels, we recommend that you switch that person to 3-drug oral ART until we know more about this particular long-acting regimen in pregnancy. Here are the data that led to the promotion of bictegravir FTC TAF. There's more safety data as of January of this year, close to 540 live births where the infant had first trimester exposure. The congenital anomaly risk was about 4%, and this is quite comparable to people without HIV in the US, so no signal for a congenital abnormality problem with bictegravir. And then there's also PK data, 2 studies, one from the manufacturer, one from the Impact Network. Both studies show that bictegravir levels go down during pregnancy, but, and this is the important part, those levels are lower during pregnancy, but they exceed the levels anticipated to inhibit HIV. And so these are the data that really led to the promotion of bictegravir FTC TAF. Okay, I'm going to now switch for a moment to TB treatment. So we have a robust section on both ART therapy in people with active tuberculosis, as well as ART dosing in people with latent tuberculosis. So let's start off with latent TB or preventative therapy. So here we recommend tenofovir with FTC or TAF with one of the following. So if they're getting the 3-HP regimen, that's the H here stands for diisoniazid, the P stands for rifapentine. That's a weekly regimen for prevention of tuberculosis. If they're getting that weekly for 3 months, there are now enough data to support using dolutegravir once a day with 3-HP that we think that that's safe and efficacious to do. So if your patient is getting 3-HP, fine to give the dolutegravir 50 milligrams once a day. If they're getting the 1-HP regimen, this is isoniazid with rifapentine given daily for 1 month, a more kind of a foreshortened course, but given daily. Here we suggest that you give dolutegravir twice a day because of drug-drug interactions, and there's just less known about this particular combination. If you've got a person with active tuberculosis and they're getting rifampin, here we suggest that you give 50 milligrams twice a day of the dolutegravir. This has been in place for a few years now, and that's because we just don't have longer-term data with once daily dosing of dolutegravir there. That data is accumulating, but for now, twice a day for the dolutegravir. And then efavirenz can be used in this setting for active or preventive TB. Okay, so now we're going to go off from initial therapy to a very common issue of switching ART in the setting of virologic suppression. So these are people who are already suppressed. What are our options here? So a couple of new studies support the idea that if you have a person with HIV who's suppressed on a regimen that has a boosted protease inhibitor and 2 nucleosides, it is fine to switch them to dolutegravir plus tenofovir FTC or 3-TC or bictegravir FTC TAF. And that's regardless of known or likely prior nucleoside RT inhibitor resistance. The one stipulation is that they don't have a history of integrase resistance, but if they don't, there are two major studies. One is called the 2SD study, and the other is called the study done at Gesco in Haiti that really support the fact that you can safely switch people off a boosted PI onto an integrase inhibitor that has a high barrier to resistance like dolutegravir or bictegravir. So that's one new recommendation. The other recommendation is that we have for a few years now recommended injectable cabotegravir long-acting plus injectable rilpivirine long-acting, particularly for people who are experiencing stigma or other adverse consequences of taking a pill every day, or who prefer injectable therapy over oral daily therapy. Now, I do counsel patients, we do recommend counseling patients that there's about a 1% risk of developing virologic failure and resistance with the long-acting agent, so it's not zero. It's a little bit higher than the resistance with oral therapy, but still a very low resistance. And for those who strongly prefer injectable therapy, this is a very good option. And then finally, we don't recommend cabotegravir rilpivirine in people who've got documented or suspected resistance to either of the agents. And we also don't recommend it in people with hepatitis B unless you also give a hepatitis B active drug like tenofovir. Some of the data that really has informed our recent recommendations come from trials and demonstration projects in people with adherence challenges. So this is asking the question, does injectable therapy have a role in people with adherence challenges? There's a study that's been presented, soon to be published, called the Latitude study. This is an AIDS clinical trials group study, and it looked at people with difficulties adhering to oral antiretroviral therapy who got oral standard of care ART with conditional economic incentives, essentially financial incentives, until they got virologic suppression. And then that group of individuals who had trouble adhering to therapy were randomized to monthly long-acting injectables or continuing oral daily therapy. Here are the results. Mainly, the main result is that regimen failure was lower in the injectable group. And what that was comprised of is a lower rate of virologic failure in the injectable group and a lower rate of treatment-related failure. So when the team looked at all of the endpoints together, they concluded in their presentation that injectable therapy in this very important group of people having trouble adhering to oral therapy, that injectable therapy was superior to daily oral therapy. There are also a number of demonstration projects supporting the use of injectable cabotegravir rilpivirine in people with adherence challenges. A study from San Francisco in 57 individuals who were viremic, viral loads in the 16,000 range, found a 95% rate of virologic suppression. 2 participants did develop resistance, and the median injections range from 2, the number of injections ranged from 2 to 18. A US-based database called the OPERA database looked at 93 people who were viremic, median viral load, also about 16,000. Here, the viral load suppression rate to less than 200 was 90%. Resistance was not presented. And finally, a study, a case series really from Mississippi, looking at 12 individuals. Here, the mean viral load was very high, 150,000. Viral load suppression rates of 100%. Median follow-up, range of follow-up was as little as 1 month, but as long as 17 months with a range in between. So before switching to our recommendation, I also want to highlight one other very, very important group, which is adolescents living with HIV. These are new data from the MOCA study, kind of a very attractively named study, looking at adolescents with HIV. And we know that adolescents with HIV can have difficulty adhering to daily oral ART. So this study looked at 144 adolescents who were all virologically suppressed. They were from the US, but also from sub-Saharan Africa and Thailand. It was a single-arm study, and participants were switched from daily oral therapy to injectable cabotegravir rilpivirine. The median age in this study was just under 16. It was 15 years of age. Almost all of them had vertical HIV acquisition, 92%. And 94% of the participants maintained virologic suppression at week 48. There were no virologic failures, and everyone in the study preferred the injectable over daily oral ART. So earlier this year, and then recapitulated in the new guidelines from 2 days ago, the IAS-USA panel is recommending that in people who are having difficulty with taking oral antiretroviral therapy, that when supported by intensive follow-up and case management services, that injectable cabotegravir or rilpivirine may be considered for people with viremia who meet the criteria below. They have to be unable to take oral ART consistently despite extensive efforts as well as clinical support. They have to be at a high risk of HIV disease progression, and this is because people with a CD4 count of less than 200 or AIDS-defining complications are at the highest risk, of course, of progressing if they don't aren't treated with successful antiretroviral therapy. And then they have to have virus that's susceptible to both cabotegravir and rilpivirine. Now, it's important to state here that the medications are just one part of it. It's really the support that goes along with the medication. If they have mental health issues or substance use disorder, the treatment for those conditions conjoined with support that make this successful. And that's really the essence of how to think of this, at least for these vulnerable populations. And I'm happy to come back to that topic during the Q&A. All right, so now we're going to ask you a question and ask you to take out your get ready to vote. This is a 50-year-old woman with HIV, CD4 of 500, HB RNA of 500,000. She doesn't have any resistance mutations on pre-ART genotyping. She started on one of the preferred regimens, bictegravir FTC TAF, and at week 12, her HB RNA declines to 100 copies. And then over the next 12 months, the HB RNA fluctuates between 50 to 100 copies. It doesn't quite get to undetectable. In our lab and many labs, it goes down to 20 copies, and she's just staying between 50 to 100 copies. So here's the question. How should she be managed? So would you, A, add another drug, in this case, an NNRTI like doravirine? Would you change your regimen from bictegravir FTC TAF to darunavir cobicistat TAF FTC because of concerns for resistance? Would you evaluate for drug-drug interactions, or would you send a proviral resistance genotype? So how would you manage this person who's fluctuating with low-level viremia between 50 to 100 copies? Let's see what you all think. Okay, so it looks like the most popular choice is to evaluate for drug-drug interactions, and then the second is to send a proviral genotype. So I would agree with the importance of checking for drug-drug interactions, and I'll go through that in a minute. And we'll also touch on some of the limitations, I would say, of the proviral genotype. I have sent it. I'll tell you in what circumstance, but it does have some limitations that are important to know. So we'll go ahead and go on to the next slide. So persistent low-level viremia. So of course, the goal of ART is to suppress viral replication, and ideally to suppress viral replication to below the limits of detection. But we all have patients who are on ART who have low-level viremia, which we define as having viral loads between 20 to 200 copies. If they have above 200 copies, I think that's not the person we're talking about, but between 20 to 200 is a relatively common occurrence. So here are some of the steps that we suggest taking. Assess adherence, for example, pharmacy refills. Importantly, consider drug-drug interactions. I would say the most common scenario that I've seen low-level viremia is in people taking multivalent cations, because these impair the absorption of integrase inhibitors. And these cations include calcium, magnesium, and iron, but also include zinc, which can be in supplements. A number of the bodybuilding supplements have zinc. And so definitely make sure that if people are taking multivalent cations, that they're taking it at least 6 hours away from the integrase inhibitor. Intercurrent illness, but we used to see transient viremia in people with the influenza, other infections, but that usually is transient. It typically is not sustained. Malabsorption is really quite rare. And if you have persistent viremia and other possibilities are excluded, then that low-level viremia may actually be due to release of virions from a viral reservoir without ongoing replication. I was involved with a study a number of years ago that looked at changing or adding antiretrovirals to people with low-level viremia, and we really found no effect on reducing low-level viremia. So in general, we don't suggest changing medications just for low-level viremia. Now, some of you talked about sending a proviral genotype. Proviral genotype is a way to assess whether there's resistance-associated mutations, not in the RNA, not in the replicating virus, but in the DNA, the HIV DNA provirus. But a couple of important things to keep in mind in terms of limitations of the proviral genotype. More than 90% of HIV DNA proviruses are defective. They're actually not replication competent. And so if you find a mutations, it's possible that it's in a defective virus. So that has to do with the specificity. There's also some issues with sensitivity. In a study that was published a few years ago, only half of people with HIV who had M184V, historically, the patient had either a genotype electronically or another genotype that showed they had an M184V when they weren't on therapy. Only half of them had M184V on a proviral genotype, so that speaks to the low sensitivity. More recently, there was a study presented at CROI this year in people on suppressive ART who had longitudinal proviral genotyping, and half of the time, resistance mutations had variable detection. What that means is they had several proviral genotypes and they would find a mutation one time, but not another, or vice versa. So there's some variable detectability. And then finally, proviral genotyping is not validated. So personally, I do sometimes send it. It's rare, but I interpret it cautiously. If I find a mutation, I generally take it into account when selecting a new regimen. But if I don't find a mutation, it doesn't exclude its presence. And I work hard to try to get old genotypes if I can. So that's my personal approach. In general, it's a test of limited utility because of some of these limitations. Okay, so now in the next few minutes, I'm going to shift gears and try to address her next question, which is her last question, which is what I should do to remain healthy. So, I started at the beginning saying that the gap in terms of people with and without HIV has been narrowing, but that same study that I started with shows that among those 83,000 people entering HIV care in North America, although the gap is narrowed, it's not fully closed. So even as recently as 2 years ago, there continues to be a gap between people with and without HIV in terms of mortality. It's down to about a 3% difference, but still an important gap. And the reason for that mortality gap could be social determinants of health. I think that's a very important contributor, things like poverty, inequitable access to care, substance use disorder, and smoking. But there's also a large body of literature now suggesting that persistent inflammation is driving some of that excess mortality. Here's a study that I was involved with that looked at inflammation before and after ART. This is looking at C-reactive protein. And what this graphic is showing you is that people who have high levels of inflammation before they start ART continue to have high levels of inflammation while they're on ART. And this is sometimes called an immune dysregulation legacy effect. And there's a lot of data supporting this now. There's also a lot of data linking excess inflammation to comorbidities, including cardiovascular disease. So here's my next and I think last question for you. This is a person, again, 50 years old, has CD4 count of 500, viral load of 500,000. She also has hypertension. She started on bictegravir FTC-TAF, her HV RNA goes down. But, and this is the metabolic part, her weight increases from 60 kilograms to 75 kilograms over the next year. Her body mass index is 29. Her cardiovascular risk score is 6%. And so how would you manage this patient? Would you, because of the weight gain, would you change her from the integrase inhibitor to doravirine plus TAF FTC? Second choice, would you change her regimen to a boosted PI, get her off the integrase inhibitor, so boosted darunavir plus FTC TAF? Would you start a statin or would you start semaglutide? So let's go ahead and see what you all think. Okay, so 80% or so of you would start a statin. A few of you would change to doravirine, FTC TAF, and then about 1 in 8 or so would start semaglutide. So we're gonna, I know earlier in the course we had a fantastic presentation on statins, so I'll be briefer here, and then I'll say a word about some new data on the GLP-1 receptor agonists. But before we get to statins, let me just say a word about weight gain. So we know that weight gain is common after ART initiation. In some people, it represents a return to health, but there are also a lot of data now that integrase inhibitors and TAF-based regimens are associated with greater weight gain than regimens containing tenofovir disoproxyl fumarate or efavirenz. Some of that may be due to the effect of TDF and efavirenz. I'll come back to that. Weight gain is more common in women and in Black people, and it mostly occurs during the first year of ART initiation or switch. So that weight gain phenomenon is greatest during that first year of ART. Now, Fabrins itself, as well as tenofovir disoproxil have been associated with less weight gain, and there are some data suggesting that that may be due to an effect on appetite. But what seems to be becoming clearer and clearer is that changing regimens because of weight gain is generally not effective. So there was an important study called the DEFINE study that looked at whether switching people to TAF FTC boosted darunavir, would that help with the integrase inhibitor associated weight gain? And really there was no benefit in terms of weight loss in the DEFINE study. Some of you voted for switching to doravirine. There is an ACTG study of doravirine switch that's ongoing. We don't yet have the results. But really, at least as of now, we don't recommend switching regimens because of weight gain, because of lack of data supporting benefit to that switch. I'm not going to go through this in detail. I know that we talked about this earlier in the course in terms of which people with HIV should receive a statin. The REPRIEVE data have really changed the landscape. Our guidelines recommend that people with HIV over the age of 40 who have a ASCVD of 5% or more should receive a statin, either pitavastatin or atorvastatin or rosuvastatin. This is a strong recommendation. And people with HIV over the age of 40 whose ASCVD is less than 5%, we recommend counseling them about the potential benefit of a statin, particularly if they have a history of prolonged untreated viremia, low CD4 cell count, previous use of older ARVs associated with cardiometabolic complications. If they don't start a statin, continue to check their ASCVD over time and come back to recommending a statin if the ASCVD goes above 5%. And then just as a reminder, all people with HIV who have diabetes should receive a statin. Diabetes itself is an indication for starting a statin. GLP-1 receptor agonists are really changing by the month, if not by the week. I want to highlight two studies that were done in people with HIV. One is the slim liver study done in the ACTG. This was a study done in people with HIV and metabolic dysfunction associated steatotic liver disease, or so-called MASLD, used to be called NAFLD. Semaglutide in the study reduced intrahepatic fat, and 29%, almost a third, had resolution of their MASLD. So that's one important study. And a second study done in people with HIV-associated lipohypertrophy, not atrophy, but hypertrophy, semaglutide reduced total body fat as well as abdominal fat. Importantly, lean body mass went down by about 6%. And both of these studies, the MASLD study, the lipohypertrophy study, the maximum dose of semaglutide was 1 milligram weekly, and that's lower than the maximum dose approved for diabetes and weight loss, which is 2 milligrams at 2.4 milligrams weekly, 2 milligrams for diabetes, 2.4 for weight loss. And I do think we need additional data on the safety and efficacy of higher doses of semaglutide in people with HIV, because those lean body mass reductions may be problematic in people who've got lipoatrophy or people who have sarcopenia. So for now, I'm recommending GLP-1 receptor agonists for people with HIV who have approved indications if they have diabetes or obesity, while awaiting additional data for other HIV-associated conditions. So I'm going to begin to wrap up with our really important section around biomedical prevention of HIV and STIs. And this is rapidly evolving, as you probably know, with new drugs coming online. But I want to start with injectable cabotegravir. Just as a reminder, injectable cabotegravir has been approved for pre-exposure prophylaxis based on two big studies. One was done in men who have sex with men and transgender women. And in that study that was published a few years ago, as compared with TDF-FTC PrEP, cabotegravir reduced HIV infections by 66%. And then a second study done in women compared with TDF-FTC PrEP, cabotegravir PrEP reduced HIV infection by 88%. So these are the two studies that led to cabotegravir's approval. Here's a really nice table, I think, that summarizes all our recommendations for PrEP as of now with approved products. So for people whose risk or whose exposure is insertive anal sex or receptive anal sex, any of these four following options should be an option. Daily TDF-FTC, on-demand TDF-FTC, daily TAF-FTC, or injectable cabotegravir rilpivirine. For people whose exposure is through receptive vaginal sex, the two regimens endorsed here are daily TDF-FTC and injectable cabotegravir. For pregnant and breastfeeding people, there are now more and more safety data for TDF-FTC. Of course, that's been around for a while, but also for cabotegravir. And then if you have a person who's got osteopenia or reduced creatinine clearance, that's if they're MSM or transgender, a transgender woman, that's where you're going to want to use daily TAF-FTC or cabotegravir. Finally, for people whose risk is injection drug use only, TDF-FTC has been studied in that setting and does work. But if they also have sexual risk factors or sexual exposures, I should say, for HIV, then you can use the PrEP option that's related to their sexual exposure, and those are the other options listed here. We do have a discussion of lenacapavir for HIV prevention. This is really changing again by the month. We mentioned the Purpose 1 study, which was using lenacapavir, studying it in cisgender women in Africa. That study showed that twice yearly subcutaneous lenacapavir, when compared to daily oral FTC-TAF or daily oral FTC-TDF, that the lenacapavir group had no cases of HIV. And also the Purpose 2 study, recently published just within the last couple of days, looked at 3,200 cisgender men who have sex with men, transgender people, and gender binary people. Here, twice yearly lenacapavir was compared to oral TDF-FTC. And here are the data from the recently published Purpose 2 study. Of 2,179 people, only 2 people acquired HIV while on lenacapavir, and that translated into a 96% reduction in HIV compared to the background incidence shown in the far left, and even had a benefit as compared to oral FTC TDF, an 89% reduction. So I anticipate in the next months, we will revise some of our guidelines as lenacapavir is approved. It's not approved yet, but it's being considered for approval. And I think that will open up the options for pre-exposure prophylaxis with another injectable option. Important point about lab monitoring. I want to spend a minute on this one because there is a change here. When you're starting PrEP, HIV screening should include HIV RNA testing as well as lab-based antigen antibody testing. But when you're monitoring someone on PrEP, we recommend doing the rapid HIV antibody test and lab-based antigen antibody test, but no longer doing the RNA testing that had been previously recommended. And that's because a positive HIV RNA in this setting may represent a false positive test, and it turns out to have a low predictive value. Diagnosis of HIV in the setting of PrEP failure can be challenging. We have a section on when long-acting cabotegravir is used, there can be delayed or even inconsistent detection of viremia, antigen and antibodies. This is called the LEVI. It's called LEVI, long-acting early viral inhibition. And then we give a really useful, I think, consultation center. Here's the number. It's also in the paper in terms of interpreting some of these difficult to interpret HIV test results. Here's one slide on preventing bacterial STIs. Why this is important, of course, is that bacterial STIs raise the likelihood of acquiring HIV. So here we have a strong recommendation for doxycycline, 200 milligrams, taken after condomless anal or oral sex in people who are gay, bisexual, and other MSM and transgender women who have had a bacterial STI in the past year. We also suggest doxypep in MSM and transgender women who have a high likelihood of exposures to STIs, even if they haven't had a recent STI. In terms of cisgender women, I think it's a case-by-case basis. Right now, the clinical trials haven't shown efficacy or effectiveness, but level monitoring as well as other data support the idea that it should be effective. So it's really a shared decision-making in cisgender women. But when used, it should be taken as soon as possible after condomless sex and not more than 72 hours after exposure. So the sections I didn't have time to cover, but I'd invite you to review are the sections on lab monitoring, a really robust section on substance use disorders and HIV, including medications for opiate use disorder and alcohol use disorder, as well as a section on future directions. But what I'll do on my last slide before concluding is really just mention a few points around promoting equity in HIV treatment and prevention. Despite a close to 40% reduction in new HIV diagnosis globally, there are increasing rates of HIV in Eastern Europe, Central Asia, Latin America, the Middle East, and North Africa. Here in the US, HIV continues to disproportionately affect Black and Hispanic people, those who live in the Southern US, cisgender, gay, and bisexual men, and transgender individuals, and people who use drugs. And there's growing concern that the new treatment and prevention options that I've been describing are not being made available to those who need them most here in the US and around the world. So I think in the years to come, we need to redouble our efforts to reduce disparities and address inequities to realize the promise of ending the HIV epidemic. It was in the last administration that the goal was put out of ending the HIV epidemic. I think in the future administrations, we need to really double down on this ending the HIV epidemic approach. About 10 years ago, a little more, on World AIDS Day, President Obama said that we should be at the forefront of new discoveries into how to put HIV into long-term remission without requiring lifelong therapies, or better yet, to eliminate it completely. Or as the patient said, in terms of trying to cure HIV, one day they'd love to say that I used to have HIV. So with that, I'm going to go ahead and stop. I hope I've left 10 minutes or so for comments and questions. Before I turn it over to our moderators, here is the publication, but we also want to invite you to, for those who want to hear more details about the new guidelines, we have a half-day session on December 12th, next week, where we're going to focus on some of the details that I didn't have time to go through today. So please do join us. Registration is free and open to all. And let me take down my slides and open it up to discussion.
Thanks, Raj. That was a great talk. Maybe Mike and I can alternate on a question. I'll ask the first one, then he can come in with the second one. But again, the symposium next week on the guidelines will be very timely. This time there are a bunch of good questions here. Hopefully we can get to some of them. But let's start with, you may be sorry you don't have a PharmD sitting next to you. But what's the difference?
I'm always sorry that I don't have a PharmD. Knowing some very good PharmDs.
What's the difference between bictegravir and dolutegravir, and how do you decide which one to use?
It's a good question. I mean, I think for all intents and purposes, they're very, very similar in that they have high barriers to resistance. It's very hard for the virus to get resistance to either dolutegravir or to bictegravir. Bictegravir in the US comes as a single pill combination, whereas dolutegravir comes as a single pill combination, but only with abacavir, a nucleoside that we use less and less often because of concerns around abacavir and cardiovascular disease. There's been links over the years, and there's some new data on that. So for those people for whom a single pill combination is really attractive, then bictegravir would be the choice. Dolutegravir has one advantage, that it's been studied a lot for second line and with other drugs. There are more data on dolutegravir with, for example, boosted PIs and other drugs. So if you have a patient where you're not giving initial therapy, but are using integrase inhibitor with other drugs, that's where dolutegravir has more data. So that's how I would answer that. Otherwise, they're very similar. One very small point, but an important point, metformin, a commonly used drug, does reduce the levels of dolutegravir metformin raises the levels of dolutegravir, doubles the levels of dolutegravir. So when you have a person on metformin, they should not be on more than 1,000 milligrams a day of metformin, because otherwise the dolutegravir raises the metformin levels to too high of a level. Bictegravir raises metformin levels, but to a lesser degree. And so that's one other time where you might choose bictegravir over dolutegravir if you have someone on a high dose of metformin. That's my clinical pharmacologist speaking.
So Raj, if you have somebody on the 1 month latent TB treatment and you're using twice daily dolutegravir, how long do you continue the twice daily after the LTBI is stopped?
That's a terrific question. Usually for a few weeks, because there's an effect on the metabolism of the dolutegravir. So I think it's about 2 weeks. I would double check that exact number, but that's David Spock spoke about this recently, and I think that's what he summarized. And because the effect of metabolism it's not like an on-off switch. It takes a little time for that effect to go away.
Raj, there are always some unanswerable questions, but maybe you have an answer to this. If a compliant patient has low level of viremia for years, why don't they progress?
It's a good question. I think if they're sitting between 20 to 200 and they're year after year at that level, I think the reason they don't progress is because that virus is not fully replicating. It's basically being released by the reservoir, but isn't setting up shop and causing immune damage in the way that active replication does. One of our colleagues, John Mellers, and his group looked at low-level viremia, and when he looked at it, these are people who had that low-level viremia for years. all of the integration sites were in an identical place, and what that meant is that the virus was not replicating and causing new damage. It was kind of just being released, but there was kind of a dead end. So I think that's why people don't progress. It is important though to tick through those issues around adherence and around drug interactions, because the people who have that low level viremia, you have to go through that process to make sure there's not a cause that you can address. But if at the end of the day you don't find a cause, changing therapy is really not the solution.
Yeah, when you're using rilpivirine in the setting of unsuppressed viral replication and those adherence questions, it's recommended to have case management. This question from Margot is that, what if they don't have a lot of case management? Could they just use increased intensive clinical support?
I do think intensive clinical support is key, and I think if the person's CD4 count is less than 200, obviously they're at high risk, and that's where you're going to want to make an intervention with intensive clinical support. I agree that not all places will have case management support, so yes, I think that's the right way. If their CD4 count is 400, though, I think the reason why we had that qualification there is that's where you may still work with them on other ways to try to have them on oral therapy. So it really depends on the needs.
Yeah, I think some sort of increased support is warranted because they're struggling with their antiretroviral therapy to begin with. And Henry?
Raj, a question that comes up at every symposium is what to do with elite controllers.
A good question. So I will tell you how I think about this, and we have covered this in the guidelines before, but not in the most recent iteration. So elite controllers, Trip Gulick, who's about to talk, did an analysis of the START study. Remember that study that I mentioned that suggested that we showed that we should start ART regardless of CD4 count? There was about 3,000 people in the START study who had a viral load of less than 3,000. Sorry, there was about 1,000 people who had a viral load of less than 3,000. He couldn't demonstrate a clinical benefit of early ART, but he certainly, obviously, when you start ART, you make people undetectable. They don't transmit, and so that's a benefit. For elite controllers, there's a lot of data now that they have more immune activation and they have inflammation. And since there are data linking inflammation to adverse outcomes, I think one can make a good case for treating elite controllers. Now, if they don't get treated, sometimes people have strong feelings about not being treated. The really important point there is to not lose sight of them. That is, have them come in every 3 to 6 months, because more than once we've seen people who have elite control lose that control. And in one instance, a person lost control and actually developed pneumocystis and died. So there is definitely a really important point of keeping people in care, even if you're not treating it. But I suggest treating elite controllers for that theoretic benefit of reducing inflammation and thereby preventing some of those comorbidities. So.
I'm combining a couple questions here just in the interest of time, but it all revolves around PrEP and HIV RNA testing, which is generally not recommended currently. However, if you're checking HIV antibody or antigen and it becomes indeterminate, that's the time to get an RNA, correct?
Exactly right. That's exactly right. And that's the time to also avail yourself of some of those experts at that hotline. But yes, I would do an RNA there, and then those are exactly the questions that you have to be kind of considered on a case by case. So.
Henry, I think we have time for one more.
Yeah, somebody asked about pregnancy and cabotegravir, and I guess the question is, if cabotegravir and rilpivirine both approved for pregnancy, why do you change antiretroviral therapy in a woman who becomes pregnant while on Cabenuva? Is that the right regimen, and is that based on data or lack of data?
It's a bit of both. So the reason why right now we don't recommend, and others also don't recommend, giving cabotegravir rilpivirine, one is there's not a lot of data for any two-drug regimen. In fact, dolutegravir 3-TC, dolutegravir rilpivirine, these are oral drugs. We don't recommend those as a first choice in pregnancy because there's not much data with it. Same applies to cabotegravir rilpivirine, even though they're FDA approved. There's not a lot of data what they're used during pregnancy, and obviously the stakes are quite high during pregnancy in terms of making sure people stay suppressed. The other issue, though, is there was some reports relatively limited data that the levels of the drugs during pregnancy for cabotegravir rilpivirine, that some of those drugs go down substantially in terms of the drug levels. Now, again, these are few and far between. There's not a lot of data yet, but that, it's just trying to avoid a situation where someone develops viremia while they're pregnant while on cabotegravir rilpivirine. So that's where that came from.
Yeah, I think we're going to need to move on, but thank you, Raj, and we'll reiterate that on December 12th, there will be a more detailed immersion into the new guidelines, and that'll include case-based presentations, and a lot of the questions that are asked here are going to go into great detail. So thank you very much.
My pleasure. Please join us next week, and good to see all of you.